All right, guys, so today I'm going to be discussing pleurisy. The membrane of the lungs is called the pleura, and sometimes, due to usually secondary to viral infections, the pleura may become inflamed, and that can lead to an accumulation of infected fluid in the pleural space, which can be called empyema. So let's review those basic terms real quick. So today we'll be discussing pleurisy, and pleurisy is inflammation of this orange sac that you see around the lungs. The pleura itself has two sides to it and a space in between which provides lubrication. The fluid inside is known as serous fluid, and every time that the lungs expand, they rub against the intrathoracic cavity and they glide because of that fluid, which remains friction-free, and it allows the patient to inspire and expire easily with no friction issues. Also remember, the mediastinum is where you have the heart, and so every time the lungs expand, they squeeze the heart. Without the pleura, without the lubrication provided by it, the patient's going to have some pain because it's going to be squeezing the heart. But in this particular condition, the physiological purpose of the pleura is to reduce that friction. So when it's not inflamed, the patient can breathe in and breathe out with no particular issues. However, during pleurisy, there's two sides of the pleura. The part that's touching the actual lung, that's known as the visceral membrane, and the one that's touching the intrathoracic cavity on the outside, that's known as the parietal membrane. And in between, you have that fluid, that serous fluid. And so when that fluid becomes inflamed, usually secondary to viral infections, but it could be other microbes as well, we call that pleurisy. So you have to think about, what's the whole purpose of the pleura? It's to reduce friction. But now that it's inflamed, the friction reduction ability is going to be decreased. And now you'll develop something called pleural friction rub. And this is an adventitious breath sound that you're normally going to hear when the patient's breathing in and out, and it sounds like a rubbing sensation as the lung glides, well, not glides, as it rubs against the inside of the thoracic cavity, because that fluid is no longer there to provide lubrication. It's now there and it's causing irritation and friction. So that's what happens secondary to pleurisy. One thing that you guys want to keep in mind is that the heart itself has a sac as well. We call that the pericardial sac. And that pericardial sac may also become inflamed. It's called pericarditis. How do you distinguish whether it's pleural friction rub or pericardial friction rub? It's a quick way. The heart's constantly pumping. The lungs only expanding and contracting when you're breathing. So when you're auscultating for the breath sounds, you want to find out, are you hearing the pleural friction rub only when the patient's breathing, or also during the pausing moments of respiration? So what you do is you have the patient take deep breaths in and out, okay, you're listening for it, and then you have the patient not breathe. If you don't hear the pleural friction rub when the patient is apneic, when the patient's not breathing, then you understand that it's going to be pleural effusion. But if you hear the friction rub as the patient's also, when the patient's not breathing, well, you understand that it's probably the pericardial friction rub. So that's how you distinguish pericardial friction rub from pleural friction rub. You have the patient not breathe for a few seconds, and if you don't hear the sound, the pleural friction rub, when the patient's not breathing, then for sure it's going to be the pleurisy issue. When the membrane becomes inflamed and the infection is not taken care of, now we can start developing an accumulation of fluid all throughout the sac that's inflamed, and we call that pleural effusion. Okay, and pleural effusion can become significantly problematic simply because the patient won't be able to expand their lungs that well when they're breathing, because there's a lot of pain associated with both of these parts of the condition, whether it be pleurisy or pleural effusion. There's going to be a lot of pain, a lot of inspiratory pain. So, inspiratory pain. That's how you can truly identify the pleural effusion or the pleurisy being the main issue and not another condition like pericarditis. The accumulation of fluid can be significant. We call that infected fluid that accumulates in the pleural space empyema. Okay, and so empyema is going to be the fluid that collects inside the pleural space. And what ends up happening is the lung can no longer expand to its full potential as it's restricted in this fashion. And the fluid that's accumulated, which I'm going to draw in blue, It's all inside the pleural space. And so it's preventing the lung from fully expanding, and this is going to cause a lot of secondary respiratory issues, shortness of breath, dyspnea, pain upon inspiration. And when you auscultate, the location right here where you have the accumulation of fluid, you're not going to hear any breath sounds because the sac is outside the lung, not within the lung. So you're not going to hear crackles. A lot of students make that basic mistake. They assume because there's fluid inside the lungs, well, it's not fluid inside the lungs. It's fluid inside the sac, the membrane that surrounds the lungs. And so that pocket of fluid is putting pressure against the otherwise space where the lung would expand. And so when you're auscultating for adventitious breath sounds, for abnormal breath sounds, you're going to have an inability to hear when you're auscultating right there because the air is not going through all the way there. The lung is not expanding all the way through because the pressure is being placed and it's restricting the expansion of the lung. Keep in mind that your main issues are going to be dealing with respiratory insufficiency, impaired gas exchange, hypoxia, hypercapnia, and the longer this continues, the worse it gets. The exacerbations do continue. So what's the goal, folks? Well, when we talk about your initial interventions in aiding this patient in the respiratory effort, well, you want to do things like sit the patient up, provide pursed lip breathing, give oxygenation. Depending on what their saturation is, you either give nasal cannula, which can give you up to 7 liters of oxygen, and if not, you do the simple mask. But keep in mind that even though the simple mask can give you up to 15 liters of oxygen per minute, they do have the little holes, so the patient's still breathing some atmospheric air. Once the patient's condition starts deteriorating, once the condition exacerbates, and the patient's saturation is going below 90, below 85, let's say, now the patient's going into severe respiratory distress. At that point, you want to place a non-rebreather mask to maximize the oxygenation concentration that the patient's going to be receiving. So, aside from positioning the patient's head of the bed elevated, aside from pursed lip breathing, what else can we do to alleviate this? Well, we should have the working understanding that the doctor's probably going to provide an order for a thoracentesis. And the thoracentesis is the term that we use to describe when the doctor, the practitioner, gets a needle, they insert it through the chest cavity inside the pleural space. Okay, and what we do is we aspirate that fluid. A couple key points that you guys should keep in mind when patients undergoing a thoracentesis. As the patient breathes in and out, that lung still wants to expand a little bit, but of course it's being restricted by the fluid. So the lung does want to come out when the patient breathes in. And as you're retrieving that fluid, that volume is decreasing and that lung will be expanding. You must take precautions between the space of the needle and the lung tissue, and you don't want to puncture it because you may develop a pneumothorax, which is a whole other monster right here. You want to educate your patient when the doctor's performing a thoracentesis to not cough, to not take deep breaths. Okay, so you want to avoid those things because anytime the patient takes a deep breath, anytime the patient coughs, the lung tissue is going to be expanding more so, and it's going to risk the likelihood of them puncturing the lung and therefore developing a pneumothorax. You must educate the patient on the appropriate positioning for the thoracentesis. You must place the arms over the bedside table if possible, exposing the area where the doctor is going to be accessing the lung tissue or the pleural space for the retrieval of fluid. You must ask the patient to sit up high. Now, if for whatever reason the patient can't tolerate that position, then you put them on a sideline position, on a high Fowler's position, or maybe about 60, 70 degrees, maybe not 90 degrees, but maybe 60, 70, with the affected side up so the practitioner could still access it. The arm may be elevated. Okay, keep in mind that when they do this procedure, they're going to be providing some local anesthetics, and the thoracentesis is going to be guided with an ultrasound device so they can make sure they don't puncture that lung. After your procedure, you have to remember to assess breath sounds. Now remember, we discussed assessing breath sounds prior to the procedure. What are we going to hear? Nothing. So you may get questions on NCLEX that ask you, so how do we determine the effectiveness of the thoracentesis, or the therapeutic results of the thoracentesis? Well, we auscultate breath sounds, and what we should be hearing is some type of breath sounds, because that means that the lung expanded well. If at some point we're doing our post-procedure assessment and we hear absent breath sounds, that's a red flag. Maybe that indicates that we punctured the lung and the patient now developed a pneumothorax. So you have to play with the topics. You have to play with the concepts to ensure that you understand the potential complications that the patient may develop after a thoracentesis, guys. Okay?